So many people until very recently said, is this the price of success? No surprise that older people have an increased risk of mortality. Younger people may now be living long enough to die from other causes. That's success. That's good news. Or is something a little more subtle going on? Results from the Strategies for Management of Antiretroviral Therapy, or the SMART study, really has changed, I think, dramatically the way we look at HIV infection in the post-HAART era. The first thing I would like to draw your attention to is the totals on the far right. So when you combine the results from both arms of the trial, which was a trial looking at whether or not interrupted therapy caused people to have fewer toxic events, we find that the most events were actually non-HIV events and not death. They were major coronary artery disease, renal, or liver disease. There were 104 of those. The second most common event was all-cause death. 85 people died. If you look at non-serious OIs, there were a few of those. If you look at major OIs, the kinds of things that we were really working hard to manage pre-HAART, they were extremely rare. Well, the story gets even more complicated because the trial was designed to look at the effect of giving people basically structured treatment interruptions to avoid toxicity from long-term treatment. And the assumption was, while people who had constant treatment would have better CD4 cell counts and better viral loads, that they would have more toxicities, i.e. coronary disease, renal disease, and liver disease. So the assumption in the trial design was that these events are toxic events. What they found was that people who had constant therapy had fewer, quote, toxic events, as well as better CD4 cell count, better viral load, and better survival. So that caused us to really reassess whether or not these events were truly toxic events or, in fact, associated with HIV disease progression. Non-AIDS disease is influenced by HIV treatment and behaviors and conditions associated with HIV infection. So wait a minute. You just told us these were HIV events. Well, they are. And now you're telling us they're also related to treatment and behaviors and conditions that one may have even before one gets HIV? Yes, I am. Here's a case history. A 52-year-old past IV drug user who has both HIV and hepatitis C co-infection. He started CART therapy 8 years ago and has achieved undetectable virus. His CD4 count is currently 250, but he dies with hepatocellular cancer. Was this an AIDS death? If I told you that the individual also drank heavily, would that change your opinion about whether or not it was an AIDS event? So this person had substance use, both drugs and alcohol. Actually, he had stopped using IV drugs, but had started drinking heavily and had continued to drink relatively heavily. He had intermittent adherence. So even though he had achieved viral undetection, his constant inflammatory condition might have been higher than otherwise. He had viral hepatitis. He may have had medication toxicity, both from his antiretrovirals, but importantly, people with HIV are on as many medications for non-HIV as they are on HIV medications, and some of those also have liver toxicity, like Tylenol. Like Tylenol combined with narcotics can certainly affect one's liver function. Finally, he had HIV infection and chronic inflammation on that basis. All of those things contributed to his liver disease. So I would contend to you we need to stop worrying about whether something is an HIV disease or not an HIV disease and recognize that HIV plays a strong silent partner role in many of these conditions and that we need to think how to optimally manage them no matter what the etiology is. Here's another piece of data to support that observation, and this comes from the DAD study. These are risk factors for hepatic mortality, so they looked at all their deaths and categorized them by cause of death and then tried to predict who would die of hepatic causes. And they found that while CD4 count had an association, and viral load did as well, age was an important risk factor, as was drug use, which is probably a proxy for hepatitis C co-infection, as well as hepatitis B infection. Oh, I'm sorry, they also have hep C infection, but some of those individuals may not have been tested. So you can see that there is a strong association with traditional HIV markers, CD4 and viral load. But there are also strong associations with age and with other risk factors. And I think this is going to be a very common story among our patients who are aging, that it's not going to be one or the other, it's going to be all of the above, as is commonly the case in geriatrics. Alcohol and liver disease. This is data showing the association between FIB4, which is a marker for clinical cirrhosis. It's not someone with a diagnosis, but one who might be at very high risk for liver cirrhosis. And looking at the combined effects of HIV and alcohol, hepatitis C and alcohol, and hepatitis C, HIV, and alcohol. And in all cases, alcohol adds substantially to one's risk. How many of us routinely ask about alcohol consumption in our patients? How many people who with HIV have been counseled to cut back or stop drinking? Here's another case history. Low bone mineral density, something that's been a very hot topic recently in HIV. A 55-year-old male with HIV. His DEXA scan shows a bone mineral density 1 standard deviation below the normal. You need 2.5 to reach the diagnosis of osteoporosis. His body mass index is a 30, which is right at the line of obesity. He has a long-term alcohol abuse, and he's a long-term smoker. All of these factors have important implications with respect to his risk of fracture. We have well established that people with HIV have lower bone mineral density than people without HIV. I don't think there's really much argument about that. The argument lies with why is that true and what can we do about it, and what does it mean with respect to risk for fracture. Because if someone just has below bone mineral density but does not go on to have a fracture, the low bone mineral density may not be that important. There's been one important study looking at the risk of actual fracture among those with HIV compared to a reasonable comparator population. Low bone mineral density is certainly a risk factor for vertebral, wrist, or hip fracture, which are commonly considered the fragility fractures of interest. HIV and time on heart is also associated with low bone mineral density. One study showed that you saw increased risk of fragility fractures, lumping all three of those fractures together among those with HIV compared to those without. Both among men, it was 3.1 versus 1.8 per 100 person years for the men, and 2.5 versus 1.7 per 100 person years for the women. But look closely at this data. Here is the data from the paper. And what I want you to notice among the men who are on the left is that you actually have higher risk of, actually have higher risk of fractures earlier on, and then some decreased risk with increase subsequently. Those early fractures might be violent fractures as opposed to fragility fractures. And we have to think very carefully about how we're categorizing these things. Wrist fractures, hip fractures, and back fractures, vertebral fractures, may behave differently in our patients than an average aging population. They almost certainly behave differently than in white women, where most of this data has been gotten in the non-HIV population. Prevention of fragility fractures can be multifocal. Behavior is very important. Smoking and alcohol clearly contribute to risk, and that's something we should be recommending to all our patients. They cut back or stop smoking and alcohol. Weight-bearing exercise is also important. Am I sounding like Dr. Fried? Nutrition, calcium and vitamin C. Milk is a great source of both things, and people can have their intolerance for lactose treated much less expensively than some of these other things, and with many fewer toxicities. But bisphosphonates are effective, at least among women without HIV. We don't know whether or not they're effective among men with HIV or women with HIV. And we certainly don't know what the toxicity profile is going to be in our population. Bisphosphonates in non-HIV infected patients have been associated with commonly GI reflux and ulcers, esophageal cancer, and less commonly jaw osteonecrosis. Given the bone problems that our patients are having and the avascular necrosis they're having, we need to be careful about this. So why does it matter what the cause is? If a condition is more likely or progresses rapidly due to HIV infection, early heart may be indicated for those with or at high risk for the condition. And we certainly, I think, have hearkened on to this and begun to try to act on it. If a condition